doing a live question and answer session about primary hyperparathyroidism or hyperparathyroidism in general. We have a few questions that have come in that I would love to go through, and as we go along, anyone who comes up with new questions or new thoughts, please go ahead and write it up in here, and I would be more than happy to try to go over them and answer as many questions as I can. The more the better. Okay. So I'll start with the first question from Linda Groff Williams. I may not be expressing this the right way, but will being out in the sun, for vitamin D, for a period of time make my calcium and PTH numbers worse? Should we take care to stay out of the sun? Oh, okay. So Linda, if you mean when you have hyperparathyroidism, should we avoid the sun? That's a good question, and let me explain. All right, so it's one of my favorite charts. So when you have hyperparathyroidism, one of these 4 glands are overworking. So let's say one of them becomes a tumor. Right? So if the normal calcium levels were set for 9.0 and this tumor is set for 11.5, right? It's going to try to produce PTH enough to bring your calcium in your bloodstream from 9.0 all the way towards that 11.5, right? It doesn't care where the calcium is coming from. It couldn't care less, right? All it wants is that for that number to be closer to the 11.5. So it produces PTH, and the PTH leaches calcium out of the bones, which is why we have osteoporosis in time. And then it also goes to the kidney, where it tells the kidney to absorb more calcium back from the urine. Don't let it go so easily. And then it also turns inactive vitamin D into the active vitamin D form, which goes and increases the absorption of calcium in the intestines from 20% to 80%. Okay? Now, this tumor doesn't care if the calcium that's coming to bring your level to 11.5 is coming from your bones or if it's coming from your intestines. All it cares about is 11.5. So, if you avoid the sun, right? Excuse me. So if you avoid the sun, that helps make the precursor for vitamin D, and you have less of this, then you're going to lose more from the bones. That's it. So avoiding the sun during hyperparathyroidism, because you want to bring your vitamin D down to decrease the absorption, is going to have no impact on the level of calcium, because the level of calcium is going to be 11.5 based on the wishes and desires of your tumor. Okay? What it will do is actually get more calcium out of your bones. So there are studies that show that if you have hyperparathyroidism and you take moderate amounts of vitamin D supplementation, it minimizes bone loss. It protects your bones. So there is no reason to avoid vitamin D in the setting of primary hyperparathyroidism. Now, if you do a huge amount of vitamin D supplementation, right? If you take a lot of this, because this enzyme is activated with PTH, you may get a lot of this, which goes and may overwhelm the system. So if you're taking 10,000 units of vitamin D supplement a day, right, during hyperparathyroidism, yes, you can overwhelm the system, and you can cause your hypercalcemia to overshoot even beyond what the tumor wants, right? But if you take moderate amounts, if you're taking 2,000 units of vitamin D, checking your labs to look at your calcium, PTH, and vitamin D, making sure you don't overshoot it, right? These are easy things to check to give you information about appropriate supplementation. You should not. So I would actually encourage you not to avoid the sun during hyperparathyroidism, because having vitamin D that's appropriate amounts in your system protects your bones in the setting of hyperparathyroidism. If you overdo it, obviously it can overwhelm the system, but but they can easily avoid overdoing it. So hopefully that helps. All right. Good question. A very important question because this is confusing. There are some websites that tell you to absolutely avoid vitamin D in the setting of hyperparathyroidism, right? And that's probably because every once in a while we'll get a patient who has hyperparathyroidism, right? That is trying desperately, has had tried desperately for years to figure out their diagnosis. They finally figure out their diagnosis. They're trying to, in the setting of hyperparathyroidism where the anxiety level is heightened up, right, because of the disease, right? And then the anxiety is even heightened up more because if you have hyperparathyroidism and you haven't been diagnosed for years and you know you're ill, that there's something wrong, and you keep being told by all sorts of Western medicine doctors that it's your perimenopausal, you have anxiety issues, you have this, that, or the other, whatever, things that don't necessarily apply to you and you know that's not accurate, that increases your anxiety, right? Because your doctors, the people you're trusting with your healthcare, are not giving you the right information and you know it, right? So you come into this heightened anxious state of not knowing your diagnosis, knowing that there's something wrong, knowing that your doctors are not really clear on what's happening to you, and are giving you these standard diagnoses that don't really make sense to you, right? So you come in amped up, naturally so, right? And you try to figure out, on your own, you have probably figured out you probably have hyperparathyroidism, force your doctors to do the appropriate labs and get you to the diagnosis. And now that you have lost faith and trust in these doctors, you try to do your own thing. So part of that is, maybe if I take vitamin D, I can bring down my numbers because vitamin D can suppress PTH production, right? And sometimes I'll get a patient in that anxious state where their ability to have faith and trust in their doctors has been diminished. They may overdo it on vitamin D supplementation, right? And they go in higher doses, and then they overwhelm their systems and get into trouble. So those patients are out there naturally because of the history of this disease and how it gets diagnosed and how we all come to this thing, right? And when that happens, you have already a person who's hypercalcemic from hyperparathyroidism, and then they get vitamin D toxicity and get even higher calcium numbers, and they can get into trouble. That does happen. It is not a common occurrence. It is a rare occurrence, but when it does happen, it's really awful, right? Because I've seen patients who get so hypercalcemic so quickly, right, when they overdo it, that their numbers become absurd, and they may get symptomatic, right? They may get, there's reports that people have had heart issues and strokes and things like that from these hypercalcemic events, right? So I caution vitamin D supplementation if you're doing more than moderate amounts, right? Measure it, test it, and then you'll get an appropriate answer as to what you should do and where you should go with it, okay? Hopefully that's helpful. Good question, Linda. All right, moving on to Jacqueline Bibb. Hello. Please may I ask a question? Of course, Jacqueline. As there seems to be some conflicting evidence out there, is there a link between hyperparathyroidism and osteoarthritis? Okay. Also a very good question. So osteoarthritis is when chronic irritation causes joint inflammation, right? And bony overgrowth, right? So the bones have growth on the ends of them, right? And those extra bones at the edge start rubbing against each other and give symptoms. That's part of the, right? Hyperparathyroidism doesn't cause this extra bony growth, even though there's extra calcium in the bloodstream, as in the early stages of it. In a very advanced stage where you have such hypercalcinosis, is called, that you have so much calcium in your bloodstream that it starts inserting into tissue, skin, tendons, and things like that, yes, anything can happen, right? But in the earlier years, which is probably the first decade of having hyperparathyroidism, it is unlikely for you to get all these bony growths or calcium deposits that would cause. So osteoarthritis is not a common or main complaint of hyperparathyroidism. Joint pain is because, and let me show you. When you look at the symptoms, number 2 symptom is joint pain, bone and joint pain. But that's because there's PTH receptors in cartilages, right, that make up your joints. And that PTH receptor may cause changes in the cartilage in the joint that create discomfort, right? But it's not causing osteoarthritis per se, okay? Good question, Jacqueline. All right. And usually when you have joint pain and bone pain from hyperparathyroidism, when you do the surgery, all that goes away if it's only exclusively caused by hyperparathyroidism. All right. All right. So next question, Annette Rivezzo. On my recent labs, my vitamin D was on the low end of normal, 26.6. And some would argue that's below normal. Some people use 30 as the number for low end of normal. But my vitamin 125 dihydroxy was 89.3, with 81.5 being the high end of normal at LabCorp. Does that indicate a conclusive diagnosis? No, that in and of itself does not. All right, that could mean you have vitamin D toxicosis, right? So let me go back to my favorite chart. So I'm going to show you the units of vitamin D first. Let me bring this up. So when you look at the units of vitamin D, the 25 hydroxy vitamin D, which is the storage form of vitamin D, which is what we usually test for, is measured in nanograms per ml. The units of 125 is picograms per ml. So 1 nanogram per ml is equal to 1,000 picogram per ml, right? So these units are 1,000 times apart, okay? So just bear that in mind. So when we go back to this chart, and you're looking at conversions, remember, this one is measured in nanograms per ml, this one in picograms per ml, right? So even if you have 26.6, a low PTH, that's equivalent to 26,600 of precursors to make this, right? And your number is 81, right? So you have plenty to still be toxic on this, right? So even though your precursor is lower than what we would want, you're making more than enough of this version to be toxic, okay? How does that happen? Well, usually that happens when your PTH is higher than it should be, and that PTH being higher is activating an enzyme in the kidney that only exists in the kidney called 1-alpha hydroxylase, which transforms this inactive to the active form, right? So this happens more often in hyperparathyroidism, but just in and of itself, you can't say that if you see this, that it's purely caused by hyperparathyroidism. You need to look at your calcium, PTH, and the 2 vitamin Ds to be able to figure out if that proves hyperparathyroidism. Now, if you have an imbalance between your calcium and PTH, meaning in a normal parathyroid environment, when your calcium goes down, your PTH goes up, right? When calcium is up, PTH. That's a normal parathyroid reaction, right? And if you don't have that, if you have high normal calcium, right? So upper end of the screen, let's say the screen is the limits of normal, right? If you have high normal calcium and your PTH, instead of being low, 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 it's high normal or elevated consistently, if you have this picture, then you probably have hyperparathyroidism. And then if along with that you have really high 125, then that kind of correlates with what you're having, okay? And so you have to fill in the picture. You know, you can't use one number, either calcium, PTH, or vitamin D's to say this is the diagnosis. You have to look at the whole picture. Now, sometimes you have a calcium of 11.5, really, really high, right? Trying to bring it in the screen, calcium high, and then you have a PTH that's also really, really high, PTH of 300. That's easy to diagnose. In that scenario, if you have a 125 dihydroxyvitamin D that's elevated, that just makes total sense. In that scenario, I would actually not use vitamin D supplementation, right? I think I would hold off and let things settle as they are, because you have plenty to help you with the absorption there. And you get too much of this, you're going to get symptomatic, right? So look at the whole picture. I encourage you to look at the whole picture. If your numbers are not so clear, like a calcium of 11.5 and PTH of 200, 300, then you got to look at the pattern over time. And I would do multiple labs to look at that. All right, moving on to more questions from Annette. My calcium has always been normal, but my PTH has been elevated for 3 years. So I've been diagnosed with normal calcemic hyperparathyroidism. I've been testing every 4 months for 3 years, and this same thing often happens with vitamin D and vitamin D dihydroxy. Also, should I still supplement with vitamin D given my active is too high? I would hold off on that, because part of the symptoms you're having is from too high of dihydroxyvitamin D, so there's no reason to give more ammunition there. Finally, with low vitamin D but high active, am I at risk of vitamin D toxicity? Yes, you actually have vitamin D toxicity because your active is high. So you are in a kind of a pickle, right, of sorts, because you have normal calcemic hyperparathyroidism, right? And this is normal calcemic, right? Now, normal calcemic patients have normal calcium levels and elevated PTH levels, as you do. Normal calcemic is hard to treat, and most parathyroid surgeons are avoiding treating them because of the following. When you get hyperparathyroidism, right, this is what's happening to you. So if your normal calcium is 9.0, like this video, right, and you get a mutation in one cell that's now set for a calcium of 11, right, you get a tumor that's set for 11. As the tumor is growing and your calcium numbers are going higher and higher and higher and higher, the normal parathyroids follow this curve of normal and work less and less and less. And this one is taking the system hostage and trying to get you to the 11, right? Very clear stuff. The range of normal in this scenario is 8.5 to 10.2. Your calcium level is now close to 11. Very clear high. Clearly there is a spread. So if your starting point was 9.0 or 10.0, you still have a wide spread there, right? So the spread could be from, let's say, 10 to 11. That's still a wide enough margin of difference between what you want it to be normal and what that is. So we all have a setting for calcium. In this scenario, the setting is 9.0 for this person. My calcium usually hovers, I think, around 9.5-ish, right? So my set point and my curve may look like this, okay? And someone else's may be set for 10.0, and their curve may look like this, right? Which is why you want to look at multiple numbers to look at ups and downs here, okay? In any case, the starting point matters, right? When you have someone who has a calcium of 11 or 11.5, you know at a minimum they're this far away from what they need to be, and potentially much farther, okay? Now, if you have someone who has normal calcemic and their calcium is 9.5, right? The tumor's calcium is set for 9.5, as you see here. And their starting point is 8.5, right? The spread is 1 unit. Is this the same disease as someone who starts at 9.5 and goes to 10.5? Yeah, the same amount of difference between calcium, probably the same amount of effort by the tumor to maintain this higher number by 1 unit, okay? But what if this person's starting point was 9.2? What if their original graph was here so that the spread is minimal, right? And that's why normal calcemic becomes difficult to treat, because you don't know what your starting point is, right? Your surgeon doesn't know what your starting point is. All the data out there, all the studies are not taking into consideration the starting point. They're looking at the whole population of people who are normal calcemic. So there are probably a large population of people whose spread from their normal to the normal calcemic hyperparathyroidism is very little. So they have very little symptoms, and when you do the surgery, they don't feel dramatically better. Their bones get better, right? Because they don't have a constant elevation in PTH. But the rest of the symptoms are not that dramatic because their calcium spread is not that much, and they don't have to produce a lot of PTH to maintain a two-point difference or 0.3 difference in calcium, right? So therein lies the problem with normal calcemic hyperparathyroidism. So what I try to do with my patients who have normal calcemic hyperparathyroidism is see if they have old labs from 20 years ago. You know, being that a majority of patients who have hyperparathyroidism are women in their middle to later ages, then they may have had calcium levels done when they were much younger, during maybe the time of pregnancy, if somebody was checking, their OB was checking their calcium, oftentimes, or that's the source of where I can find some old calcium numbers, okay, which is why I use it as an example. Or any other thing, if they had surgery years ago and their primary doctor checked the calcium, if it was done multiple times and it confirms that their calcium used to hover around 8.5, it was like 8.2 to 8.7 most of the time 30 years ago, and now they're hovering around 9.5s, that tells me that's a new, different number than old. So that gives me the spread, okay? Or I take a look at symptoms, right? How symptomatic is this person? Does this person have lots of symptoms? Like this, high blood pressure, depression, constipation, aches, and then low impact fracture. Do they have osteoporosis? And so on. I'll look at the list of symptoms. I go over it with them and see how much these symptoms are affecting their life. These are the most common symptoms of hyperparathyroidism. Not kidney stones, not bone fractures. Right? This is it. And so do they have these symptoms that are affecting the quality of their existence? If they do, let's investigate further. If they don't have any of these symptoms, okay, they don't have any of this. If they don't have osteopenia even on their bone density study, if their kidney scans don't show any stones, their kidney function is fantastic, then maybe they're not really being impacted by this disease, and it's worth keeping them in the observation group, okay? So normal calcemic is difficult for that reason. It's just that you don't know and you need way more information. And so Annette, if you have normal calcemic hyperparathyroidism, your vitamin D is also an additional clue that your system is being stressed, right, by your high PTH numbers. And in that setting, I encourage you to look at all the other potential reasons for having high PTH. And those are this. This chart is an important one. Secondary causes of elevated PTH. You have to look at all these possibilities, rule them out. If you, Annette, have already ruled out all of these other possibilities, okay, then you clearly have normal calcemic. Then you have to decide Is it impacting your life? How many symptoms you're having, and so on and so forth, and then take it from there. Okay? And if it's impacting the quality of your life, or you have bone loss, or your kidney is getting affected by it, then you should take action. Okay? And you should find a surgeon and an endocrinologist that is willing to hear. Right? Now, I don't blame them for not doing it. In the UK, they have this guideline called the NICE guideline. The NICE guidelines are the National Health Services guidelines for treatment. Okay, and in the UK, what they decided when they looked at the data is that anyone that has primary hyperparathyroidism with elevated calciums, even if their elevation is mild, right? Even if they are not symptomatic, it's better to treat them, right? Do the surgery, treat the hyperparathyroidism, than to deal with the cost of continually monitoring them, getting labs and scans and bone density issues, things like that. It's cheaper for them to treat that person than continually monitor them. Okay? That's what they've decided. Okay? But in the setting of normal calcemic, because the data is missing, they made no comments. They take no stand on normal calcemic, which essentially means they wash their hands of this thing for now, and the surgeons are like, okay, well, it's not in the guidelines, we're not going to treat it. Okay? And that comes from the fact that the data is sparse and not convincing enough for treatment, because probably a great number of people who have normal calcemic hyperparathyroidism, their spread in terms of calcium is not a lot, right? They're like this. They're in the category where their original calcium is close to the new calcium number. And so they're not getting a lot of benefit from it. So for now, they're staying away. Okay? So very good question, a very long-ended answer. All right, moving on. Megan Rose is asking, I've had high calcium for the past 6 years. 10.3, 10.9, 10.6, all of them above the level of normal, just slightly. 1 month ago, I changed doctors after being ignored about my concerns with high calcium levels, and my new doctor tested PTH for the first time. Calcium was 11.2, and PTH was 87. I saw an endo. She ordered more blood work, DEXA and 24-hour urine calcium, albumin, and creatinine. Okay, good. I'm waiting on the DEXA scan results and results from 24-hour calcium. I redid blood work this week as she requested, and the PTH intact is 43, calcium serum is 10.5, phosphorus is 2.3, and vitamin D is 41. In between these two visits, I stopped taking all vitamins and supplements that I was never truly consistent at taking anyways. Is it normal to see level changes this much in such a short amount of time? Endo did confirm primary hyperparathyroidism. I'm worried about the watch and wait approach. Might be taken now that PTH appears normal. The PTH is normal, but I would dare say, okay. So here, let me bring another graph. Okay. So this is my very favorite table or graph. The top one looks at the reaction of calcium versus PTH as it relates to percent maximum, right? So in a normal parathyroid, this is the curve, right? But if you look at it as concentration of PTH rather than percent maximum, the graph now looks like this, where it's ranging from 15 to 65. Okay? Okay. If your calcium was normal, right? If your calcium and PTH was normal, then when your calcium goes high, and let's say your original calcium number is not even 9.0, let's say your graph is a 9.5 graph, like mine, okay? Let's say you're here. If your calcium in this graph is 10.5, your PTH should be closer to the 10-15 range. Okay? And your PTH is 43. Your PTH is here instead of being down here. Right? That's not normal. Right? Even though your PTH is in the normal range, it's inappropriately high for such a high calcium. Okay? And so now, let's say your normal is not 9.5. Let's say your normal is 10. Even if you're at 10, at a 10.5, your PTH should be a low number. And it's not, it's at 43. So for me, when I look at your numbers at 10.5 and a 43, it still is hyperparathyroidism. Okay? You're just on a different place in the graph. Okay? And so I wouldn't judge one number in an isolation. I would say look at your bone density, look at your symptoms. If you have symptoms, which it sounds like you have because you feel like you're being ignored for a while, right? You must feel some changes. So if you have a lot of these symptoms, okay, and if your bone density or if your bone density shows bone loss, then I would take action, right? Don't relent to the wishes of the endocrinologist. Say, hey, I have this chart and these are my symptoms. Okay? You can even go to my website and download this thing here. Right? This has symptom list. You can put your labs, the different dates, put the labs in there. Right? You can mark off the symptoms you're having. Right? Whatever you have. Okay? And then the bone density shows, let's say, osteopenia. You look, say, hey, let's do an abdominal scan to see if I have any kidney stones. Okay? You do all these things, and then you sit down and say, hey, it looks like I don't have a lot of symptoms. I don't have any bone loss. Okay, I'm okay with monitoring it. Or you will say, listen, I have 8-9 symptoms. Okay, my bone density shows osteopenia. I don't want to get to osteoporosis and more symptoms. I want to have treatment. Right? You sit down and you have a convincing discussion. Right? And then if they tell you, well, your calcium is not high enough, then you go to them and say, I have all these symptoms, and look, your calcium number based on this study does not correlate with symptoms. Okay? So this study looked at when calcium was less than 11.2, 1 unit above normal, as compared to when the calcium level was more than 1. So the gray is higher calcium numbers. Higher calcium numbers don't necessarily give you more symptoms, except in the case of kidney stones. All right? Every other thing, the calcium number doesn't necessarily tell you the frequency or severity of symptoms. Okay? So that's what I would do. Megan Rose? Very good question. Thank you. Okay. Niklu76. Are blocked salivary glands related to primary hyperparathyroidism and calcium? Very good question. So, let me show you. So, salivary, these are all salivary glands, and constantly they're producing saliva that comes in the mouth. So we make 2 liters of saliva a day that comes out of these ducts. Okay? And if you don't drink enough water and you get dehydrated, the saliva gets thicker and gelatinous and may block the system. So that's one of the reasons for getting blocked salivary ducts. Or you can get stones. So if you're not hydrating well, some of the sediment in your saliva can collect and turn into a stone and block the duct. This is the duct. Okay? Let me draw it in green here so it's more obvious. This is the duct that has a stone blocking it. right? And these stones are calcium stones, but they have nothing to do with the calcium level in your blood. They have to do with the amount of hydration and sedimentation. So people who have hyperparathyroidism don't have an increased risk of making calcium stones in their salivary ducts. Fortunately, at least. That's a fortunate thing. Mani Du is asking, it's safe to take sinic acid to low calcium levels while waiting for a surgery? Well, that's the idea. The idea is to, you know, if you're not a candidate for surgery, or if it's taking a massive amount of time because your healthcare system is overloaded or so, whatever, to get to surgery, it is a good idea to take sinic acid to bring the calcium and PTH down, because half the symptoms are from calcium, half are from high PTH levels. By using sinic acid, at least you minimize the progression of disease to some extent, and obviously make some of the symptoms better. So it is a good idea when if you're gonna have surgery in 3 months, then it's not worth it, all right? But if you're gonna have it in 2 years, 3 years, then yeah, probably a good idea to do. Sharon Susher, is a 4-gland exploration recommended if only one adenoma is present? Depends on how your surgeon does the surgery, right? So let me explain. So when you have hyperparathyroidism, you either have adenoma or adenomas, okay? Sometimes 85% of people have one adenoma, right? 15% will have 1 and 2 adenomas, right? Which means that this one is producing a lot of PTH also. Okay? And then roughly 5% have multi-gland disease, or not multi-gland disease, hyperplasia, where all 4 are abnormal. Okay? So, for this 85% of people who have only one, if you do a scan that shows 1 adenoma, you go in there and you take this one out. Now, the one thing I want you to notice is that the normal parathyroids, in a normal parathyroid environment, all 4 parathyroid glands are roughly working equal amounts and producing equal amounts of PTH. When this tumor develops and producing a lot of PTH, these normal parathyroids that are not working they shrivel up and become smaller, all of them. Okay? And so, when you're doing surgery to take this abnormal parathyroid out, and then you go look for the other 3 parathyroids, you have to bear in mind parathyroids have a blood vessel that goes in and one that comes out, all of them. And it comes from the same end of it, the same pole. These blood vessels are much smaller now when the parathyroid shrinks. Everything in our body works on efficiency. If you're not, when you've seen people who are pumping iron and their muscles are massively big, have big, huge veins all over their body, right? That's because the muscles need more blood flow, the blood vessels get bigger. When the muscles are small, like my blood vessels are not massive, they're tiny, right? Because they don't require as much. And so therefore, these parathyroids that are smaller have smaller blood vessels. So if in the process of going in there and looking for all of these other parathyroids, you knock off one or the other blood vessel, that parathyroid dies. So in the setting of a parathyroid adenoma, you're looking not only for a smaller parathyroid, which is harder to find, you also have the potential of harming them by trying to biopsy them or potentially damaging the blood vessels going into them. If you damage the 3 remaining parathyroids, right, in the process of trying to find them, then once you take this out, that person has no functioning. Did you gain anything by looking at them? Not really. Okay? So, 30 years ago, when I was in residency, we would routinely do 4-gland exploration because at the time, we didn't have any other technology helping us during surgery, right? So this is a 30-year-old way of doing surgery, looking at all 4 glands, okay? And there were some patients who would wake up with no parathyroid function as a consequence of doing it that way. Everybody hated doing parathyroid surgery then because the potential for replacing hyperparathyroidism with hypoparathyroidism is not only daunting, it's just terrible. It's not what you want to do. You're trying to help the person. You're not trying to replace one problem with another, okay? And so then the radio-guided surgery came in because sestamibi scans became mode, and we had the probe, the Geiger counter that we could use in the operating room. And so we were injecting with radioactive stuff, seeing which one is picking it up, and then taking that one out and looking at the other ones. And at first we were doing that, and it was working out, and then we realized now that the Geiger counter is not so great, and some people moved on to still going and finding all 4 rather than just use the Geiger counter to find the most active one and take it out, right? And taking a piece out from every parathyroid, sending it to the taking it out of the body, and with a Geiger counter, seeing how much count it has. If the count was low, we would leave those particular parathyroids in place. But again, that runs the risk of damaging a parathyroid, okay? And so when rapid PTH testing came into play, right, prior to that, a PTH test would take 3 days. Once rapid PTH testing came about, it took about half an hour or so to get that, right? So if you have a parathyroid adenoma that's producing a massive amount of PTH, this 120, most of it is from this tumor. And when you take it out, because the half-life of PTH is somewhere around 4 minutes, let's say 5 minutes. In 5 minutes, if I check this, whatever PTH this thing is producing, this amount should go down by half at a minimum. So I check it at 5, 10, and 15 minutes. So if it goes from 120 to 55 at 5 minutes, 30 at 10 minutes, and 22 at 15 minutes, right? I know it's come down and plateaued. That tells me the other 3 glands are not overworking. I don't need to go look at them, okay? On the other hand, if I have 2 parathyroids, right? Let's say on the scan, only this one was the one that showed up, and I do the surgery, I take this one out, and check your PTH level, and it goes from 120 to 85 at 10 minutes, 82 at 15 minutes, and 80 or 79 at 15 minutes, let's say, then I know there must be another gland overworking. That's when it's worth going and looking at the other glands. Because this is telling me physiologically that there is another overactive gland. Does this surgery take longer? Yeah, because I had to wait half an hour to get this result potentially, let's say. And at our hospital's lab, it takes about 15 minutes or so. All right, that's pretty quick. So not half an hour, but it takes another extra 15, 20 minutes to get these results, okay? And so if you want to do multiple parathyroid surgeries in a day, it doesn't work out for you. But if you want to do a surgery well thought out in a deliberate fashion, this makes sense because I've minimized. So to me, a minimally invasive parathyroidectomy doesn't mean only a small incision. It means being minimally invasive under the surface. So if I'm going in and looking at all 4 glands and I'm going to both sides of your neck, I'm not minimally invasive. I'm maximally invasive with a small incision, okay? Minimally invasive means minimizing trauma under the surface to me, okay? Minimizing trauma under the surface means going to the gland, checking physiologically what your parathyroid hormone does, and then taking action, okay? So I do not recommend 4-gland exploration when you have a clear parathyroid adenoma that's enlarged on your scans preoperatively. I recommend doing that surgery with PTH testing to guide me as to, do I need a further exploration, which happens in only 15% of cases. 10% in double adenoma and 5% in this. So in total, 15% require bilateral exploration, okay? 85% have a singular tumor and don't require it. And the PTH testing can tell me if you fit into that 85%, in which case I can avoid doing extra surgery for you. That's important to me, really important for me, okay? So that's what I say. That's what I recommend. Okay. All right. Let's look at the questions that have come in. That's questions that came in advance. Let's look at the question that have come in. All right. Shabir Syed, is there any way we can determine for how long we had hyperparathyroidism? Shabir, very good question. The only way to do it is to look at all labs and see if your calciums were like this, up and down, let's say. Let me bring. So, if your calciums were hovering around these numbers, right? 8.7 to 9.2 for a while, and all of a sudden you start seeing that your calcium number now is 9.4, 9.3, 9.6, 9.5, 9.8, 9.6, 10, 9.8, 10.2, you know, slowly going up, then you know that's when the starting point of your hyperparathyroidism is, when there was a starting uptick. But most people don't have that many calciums to be able to do that, unfortunately. Laura Given von Schriltz. Sorry about mispronouncing your name. Thank you for this. I have primary hyperparathyroidism, primary aldosteronism, and high blood pressure. I'm taking losartan and spironolactone, and my calcium rose after starting these two medications. I've heard losartan can raise calcium. Should I switch to amlodipine? I've read scary interactions between losartan and spironolactone. I'm assuming. Good question. I don't know the answer. Primary aldosteronism, aldosterone causes elevation in blood pressure, right? And so does primary hyperparathyroidism. Primary hyperparathyroidism can affect the renin-angiotensin system, which is part of aldosterone and hyperaldosteronism. And so the two systems together are causing your high blood pressure, two illnesses, right? And so I would move more quickly to treating one or the other or both, okay? Because you're just band-aiding the situation. I don't know which medications are better for the blood pressure in this scenario, right? High aldosteronism is not very common. It's in fact very uncommon. And so I don't have enough of an experience with a combination of the two together in a meaningful way. I've had a few patients that have had both to tell you about medications, unfortunately. And so the endocrinologists are probably better. If you have a nephrologist, I find nephrologists to be extremely smart people, and so they may be better at helping you with this. I don't know if you do, and sometimes cardiologists. All right? Good luck. I'm sorry I don't have a good answer for you. I'm not that smart. I am 7 weeks post-op, and my bloods have returned in a normal range. Can I develop this again, or is there any advice to prevent this recurring again? Very good question. This is coming from Emma Hazley, or Hasley. Emma, the data out there shows that if you have one parathyroid adenoma, you have a 3 to 10% lifetime chance of getting another one. So I always advise my patients to check their labs, their calcium, PTH, and vitamin D every year with their annual exam. Let's say there's a 10% lifetime chance, 90% chance that you will not get it again, probably more, okay? And the reason is that whatever environmental toxin that caused this to occur, because generally speaking, in most patients, we don't know what that is. We don't know how to have you excluded out of your environment, so we don't know how to prevent it. If I had hyperparathyroidism, if I had any tumor growing in my body, right, especially if it happens in a younger age, I would really dramatically change my lifestyle by eating healthier, not having anything that has preservatives in it or is preserved, or eating true organic, not supermarket organic, like farmers market organics, right? Um, and really clean up my environment as much as is possible, right? Um, for people who have children who develop tumors at a young age where they don't have a genetic predisposition, that means there's a lot of toxins. One of the ideas is to move to a more rural area where you have less exposures. Anyways, so that's what I would say. Nachma is asking 5 years far enough back. If you're asking if 5 years of calcium numbers far enough back, depends on how long you've had the disease. On average, before you get osteoporosis, you've have to have had hyperparathyroidism for 8 years. So a great number of patients that I see have had this disease for a decade or more. So 5 years may not be enough to give you an idea. Pamela Martin, why do the numbers fluctuate so much? My last lab PTH was on the 13 was 100, in December was 75, but it was fluctuate. It's because of this. It's because when you get hyperparathyroidism and you get a mutation in one cell that turns into an adenoma, that cell now has a new PTH number, in this case 11, right? And sorry. So this is what happened. The mutated cell is once an 11, but this 11 follows this new curve, right? So sometimes your PTH will be low on this curve, sometimes your PTH will be high, and sometimes your calcium may go in the normal range. This is the new graph. This is the normal calcium levels, right? So you may have a calcium that's normal with a really high PTH. You may have a really high calcium with a normal PTH. Okay? So the numbers fluctuate, they're just following a different graph. Miles Sundin, 3 surgeries, supposedly all glands removed except part of the one implanted in neck muscle. 15 months PTH levels normal. 3 months ago, levels spiking to 12.5 and 14.5. I'm assuming you're in Europe because your PTH units are different. In Europe, I think the PTH normals, the upper limit of normal is 6 or 7. So 12 to 14 is really high. All symptoms returning, 1 surgery, no gland found in post-surgery biopsy. Could this gland have been ruptured and regrow? Well, there's many possibilities of what's going on. So you may have you may have hyperplasia, right? And the gland that was, so this is hyperplasia, right? Progression of hyperplasia. The gland that was taken out and put into your muscle may have grown and caused you the problem, okay? You may have more than 4 glands. So you may have had 5 glands, and the 5th gland may have been somewhere else. Okay? So that's why scanning at this point will be helpful to see if you have another one. You may have, during the surgery, when they removed all of these, right? So they removed this one, removed this one, they took this one out and reimplanted it in the muscle. And in the process of removing this one, they may have ruptured and left a little piece here that has now grown. So you have to do scanning to see if you can see that. I would start with an ultrasound, and then if that doesn't show it, go to a 4D parathyroid CT scan and take it from there. If they reimplanted this in the muscle of the neck versus reimplanting it in the arm, they reimplanted in the arm, selective venous sampling is very helpful, because when you do that, if it shows that the blood flow, the high PTH is coming from here, from this blood vessel, then that tells you you have only a parathyroid in your arm that's overactive, got to go after that. In that scenario, selective venous sampling is actually extremely helpful. But you have to do further testing to figure this out. If your PTH numbers are consistently higher now, your hyperparathyroidism is now fully active, and you got to figure out if it was the reimplanted parathyroid doing it, a spilt parathyroid in the original site, one of the original sites, or you have extranumerary fifth gland, sixth gland somewhere else that's doing it. Okay, that's a tough situation, especially after having 3 surgeries. You just need someone to really look in depth at everything for you. Pamela Martin says calcium levels in June 5.57, December 5.77. So as your PTH number went up, as your calcium number went up from 5.6 to 5.8, your PTH came down from 100 to 76. That makes sense. All right? Thank you, Pamela. So your new graph, your parathyroid tumor is following a different graph, and that's why you have this. Annette Rivezzo, thank you very much for answering my prior question about vitamin D. I have a couple of follow-up questions other than osteoporosis, which I have. Does normal calcium hyperparathyroidism usually cause additional symptoms? It can cause the same frequency of symptoms as hypercalcemic hyperparathyroidism, right? It all depends on the spread between the calciums, right? If it's a larger spread, more of a difference, more symptoms. The most common symptom is, the symptoms are the same. This normal calciemic hyperparathyroidism is not a different disease. It's the same disease. So the symptoms are the same. These are the symptoms. The most common one being fatigue, and then you go down the list. Also, given my vitamin D 125 is occasionally too high, as I explained in my earlier question, what are the most common symptoms of vitamin D? Vitamin D toxicity has very similar symptoms to hyperparathyroidism, unfortunately. So, generally speaking, I tell my patients that if you have hyperparathyroidism and when you take vitamin D supplementation, you feel worse, you get more exaggerated symptoms, that confirms and further shows you that you have hyperparathyroidism, primary hyperparathyroidism, and probably getting vitamin D toxic, but it'll show up in the 125 dihydroxyvitamin D and not necessarily in the normal. So you check your normal vitamin D and it's normal, and you're feeling terrible, I encourage you to check the 125. So your doctor doesn't force you to take 50,000 units of vitamin D weekly, which is making you feel awful. Jose Barbosa. Can primary hyperparathyroidism cause anxiety with nerve hyperexcitability with muscle fasciculations? It can cause anxiety for sure. You can see it here. That's 70% of people who have hyperparathyroidism have anxiety. Generally speaking, low calcium levels cause muscle fasciculation and tetany. But I have rarely seen it in high levels as well. Adenoma removed 50 days ago, PTH dropped 75%, now normal calcemic, clean EMG still fasciculating. Well, your muscles fasciculating probably means you either have too low a calcium for what your body wants, right? In which case you would also get numbness and tingling around your fingertips or around your lips, fingertips, both hands. Or the calcium rebalancing is aggravating your muscles, and it may be a little too early for that to improve. I would not lose hope, Jose. Keep at it. Just make sure your calciums are not too low and you're supplementing appropriately or taking enough calcium through your diet so that the bones that have lost calcium can regain that. Ben Carlson, hi Ben, how are you doing? I'm pushing 76. When I think back at my life, it feels like I've had my disease most of my life, probably. Maybe starting at late teens or early 20s. Heart palpitation and stomach problems started then. Let's say, if you were to re-operate me as a third operator, would the scar tissue from the first 2 operations create a significant problem or risk? I mean, there will be more scar, but It depends on the skill set of your surgeon and how gentle they are with the tissue, including the first two surgeries. The more gentle they were with you during the first two surgeries, the less scar formation you have, right? And then the third surgeon, I'd say 95, 98% of the time when I do surgery for revision, double revision surgeries, when I go in there, the scar is still something I can work with. I can still find the nerve. I can still do things. I take all sorts of extra precautions. So, yes, it's the chance of the risk of problems is more, but the risk of problem doesn't go from 2 to 3% to 80%. It goes from 2 to 3% to 10%. Sensipar is not an option for me. It gives me stomach issues. I'm sorry. I think a lot about how many years of remaining lifetime all this can cause. 5 years since the first operation, I don't really have a serious condition, but horrible pain from my arthrosis all over and stomach problems without any found causes, plus a pretty debilitating depression. No joy of life left. Listen, I don't know what to tell you. You and I have been speaking for years and years and years, and I know I've seen your scans. I know your parathyroid seems to be in the upper chest, based on your scans, and your the surgeon who did your second surgery said that there was too much scarring to go in there. Based on what I've seen on your scan, it seems like a very doable procedure, and you know, life. It's not how long we live, it's how well we live those number of years. So if your depression is debilitating and you have pain and upset stomach, I would think that's enough reason to proceed. But I don't, again, the only person who can be a judge of that is that. Miles Sandine says in Canada. Oh, I think I was saying that based on the units of that you're presenting, you may be in the Europe. Canada uses the European system of numbering for calcium and PTH, not the U.S. units, and that's fine. Thank you for sharing. Interesting that I'm from Iran, and as you guys all recall, years ago, during the George W. Bush's time, Iran was called the axis of evil. So it's interesting to now have Canada as someone the U.S. is alienating. So welcome to the ranks of axis of evil, my friend, Miles. Anyways, moving on. Suzanne Reese, love the worksheet. Yeah, the worksheet is very helpful. All of you, I encourage all of you who have hyperparathyroidism, download the worksheet and just have it with you. It'll help. It'll help along the way. Pamela Martin, DEXA scan is good and no symptoms. Listen, if your scans are good, you have no symptoms, you have the option of monitoring, right? Especially if you have access to healthcare. All right. No more questions. We are done for the day, my friends. I hope you have a wonderful day. I hope you found this to be helpful. If I can be of any further help or assistance, send me a message. I'll try to get to it. I don't always succeed, but I'm happy to do it when I can. Have a wonderful day and month, and I will see you in the middle of the summer. Be well.